This meeting is being recorded.
Auntie Medina, I'm just going to turn off your microphone just to, oh, there you go. Oh, good. Thank you. So welcome everyone. Good afternoon, good day, depending on the time zone that you're in. And welcome to the NETFA Online Peer Exchange. My name is Rani Pramesti. My pronouns are she, her, and they, them. And I'm the Senior Project Officer for NETFA, otherwise known as the National Education Toolkit for Female Genital Mutilation or Cutting or Circumcision Awareness. Thank you so much for being here today. Next slide, please, Irina. So before we begin, I want to acknowledge that I'm joining you all from Kulin country in Nam, so-called Melbourne, and I want to pay respects to all Aboriginal and Torres Strait Islander people across Australia, and pay respect to elders and to country especially. Next, please, Irina. Just a quick note about Zoom. I hope everyone's familiar with this, but if you're not, that's okay as well. So please try to keep your phone off and not to multitask during this session, because we are going to be sharing a lot of information and presentations with you all today. So it'd be great to have your focus during the next 2 hours. Please keep your microphone off if you are not speaking, and how you do that is just to make sure that this microphone button here is off. And oh, sorry, you can't see my cursor. The unmute and mute button, make sure that that's off. And you're welcome to use reactions to show your support, your excitement. So for example, I'm going to put a love heart up right now, or a thumbs up throughout the sessions if you're, want to be supportive of our many speakers today. And if you want to ask a question, similarly, you can also click on the reactions button on the bottom of your Zoom bar and click on raise hand to ask a question. Next slide, please, Irina. Please let us know if you have any access requirements. We've already asked you this when we asked for your RSVP, but in case you're not clear what an access requirement is, it's anything that you need to be able to be present and to participate today. So for example, we will be having a break every hour so that you can just, stretch, get a drink, whatever you need. Some people may need to keep their cameras off because for whatever reason, maybe you need to rest your eyes, maybe of internet connection. Please just let us know what access requirements you have. So I'll just pause in case someone wants to speak and let us know, or you can put it in the chat, which I am also monitoring. No access requirements. Oh, Delaram's just eating lunch. Yep, camera off, all good. Okay, well, you're welcome to let us know in the chat anytime if you have another access requirement. Next, please, Irina. Today's session, so we do ask that everyone, what do you call this, adheres to the Chatham House rules in terms of confidentiality, meaning that we can use what we are learning, but if any of them concern a specific person, please use those learnings in a de-identified way so that that person cannot be easily, identified with what you are sharing outside of this space. Next slide, please, Irina. And also, given we will be discussing FGMC today, we do ask that you give a content warning if there's any content or stories that you think may be triggering or difficult for any attendees to listen to today. So for people who are not familiar with content warnings, these are basically verbal or written notices that precede potentially sensitive content. So it can be as simple as I'm for example, content warning for this next slide. I'm going to be speaking about statistics that may be disturbing for some people to hear. And then pause, and that gives people a chance to just decide whether they want to hear what you're about to say or whether they want to tap out for a little bit and then come back to the session. Next, please, Irina. So on that note, we do ask that there's no graphic content, whether verbal or visual, to be shared during today's session. And also, if you are someone who has experienced FGMC, you do not have to share your personal experiences ever. However, If you do choose to share your experiences, please try to avoid sharing really graphic details. And if you're not sure if something you're about to say is graphic, feel free to reach out to me in the chat, and maybe we can have a quick check-in about that. And like I said, this is a way that you can share, say a content warning. For example, I would like to share about my experience of FGMC, and then pause. Again, that's just to give people the chance to stay in or tap out for a few minutes. Next, please. So the structure for today is we're starting with the welcome and housekeeping, which we are already in the middle of. And we're about to go out into small breakout rooms to give people a chance, to give all of you a chance to meet each other. And then I will do a very short presentation about the NETFA Leadership Program, which has been a big part of NETFA activities for the past year. And then we will be joined by one of the participants of the NETFA Leadership Program, Patience Afor, who will be sharing a short speech about her highlights of the program. Then there's a few minutes for any Q&A, questions and answers with all of you, followed by a short presentation by Gianna Parma from TRUE Queensland, and then a presentation by Dr. Ngatho Samuel Mugo from New South Wales Health. That concludes the first part of today. Then we'll have a quick break. And next, please, Irina. Then we will have more excellent presentations by Monica Diaz and Angela Brown from the University of South Australia, followed by a presentation by Associate Professor Olayide Ogunsiji from FGMAA New South Wales, and a presentation by midwife and advocate Catherine Sesay. And if I can ask everyone to please keep your questions to the very end of the presentations in this second part especially, just because we're running through quite a lot of information today. So if possible, keep your questions to the end, or you can put them in the chat for our presenters to respond to after they finish their presentations. The final part of today's session is a short facilitated discussion. I basically, as a senior project officer, I want to hear from all of you in terms of what you think are some of the most urgent problems and challenges to do with FGMC that we can work on together as a national network. So I really want to just spend a few minutes listening to all of you so that this will inform NETFA activities into 2023 and beyond. And then we'll wrap up today's session with a what's up next for NETFA. Next, please, Irina. Any questions or comments, everyone? No, we're all good. All right. So if there are no questions or comments, I think Irina will break us out into small groups, and we'll be asking everyone just to do quick introductions. And again, this is because one of the purpose of the NETFA Online Peer Exchange is to build stronger connections across Australia with each other as people, professionals, community members, community advocates who care about the issue of FGMC in the Australian context. So Irina, if you can stop sharing. Sorry. Thank you. What we're going to ask all of you to do over the next 10 minutes is to share your names, the Aboriginal country that you're on, or Torres Strait Islander country that you're on, your pronouns, any access requirements that you need the small group to be aware of, your professional roles, and then one thing that is on your bucket list of things that you want to do. So if you're not familiar with like what is a bucket list, it's basically a list of things that you want to do before your life ends. Actually, I don't really know how to say it any other way. So this is just a way to get to know each other in terms of like what's important to you and what's one thing on that list that you feel comfortable to share with our colleagues today in your smaller groups. So a reminder, when Irina opens the breakout rooms, to click on the join button to enter the room. And then when the time is up, so in about 10 minutes, click on leave breakout room rather than don't click on the leave meeting, because then you leave the entire meeting. But if that happens, it's okay. You can just rejoin using the same Zoom link. Any questions, everyone, before we go into small groups? Okay, I think we're good. Great. So feel free to join the rooms that you've been assigned, everyone. Is there 5 rooms? Is there? Do you want me to go around? Oh, Patience is here. Why don't I stay here with Patience, Irina? And do you mind going around and just pasting the prompts in there in each room, sort of thing? I can't hear you. Sorry.
Yeah, I broadcasted and also I go around and just post it in the chats.
Thank you. I'll stay here with Patience and just get her orientated. Patience. Hi. Can you say something? Oh. Can you hear me?
This meeting is being recorded.
Welcome back, everyone. Hope you had a chance to get to know some new people. Excuse me, everyone. There's a lot of pollen in the air today in Melbourne. So, let's do our best. Irina, when you're ready, I think we can move forward. So once again, everyone, for everyone who is new to NETFA, NETFA is the National Education Toolkit for FGMC awareness. And it's also, NETFA is an Australian project funded by the federal government, which is coordinated by the Multicultural Centre for Women's Health. Next slide, please, Irina. There are 3 main activities of NETFA. So firstly, we are a national resource. You can go to our website, netfa.com.au. This year, we also delivered the inaugural NETFA Leadership Program. And then finally, we are also a national partnership network. So this is where all of you come in. And the NETFA Online Peer Exchange, today's event, is one way that we can connect and collaborate on FGMC across Australia. Next, please, Irina. So just before we get into the flow of all of today's presentations, I did just want to say a little note about what today is not. So this is a learning space, and it's not a therapeutic space. So please be mindful of this when and if you decide to share information or stories with each other today. Next, please. And a bit of a content warning, over the next close to an hour, really, we will be presenting and digesting presentations, information about FGMC. It's kind of obvious, but at least we wanted to give a quick content warning that this is the section that we're moving into now. Next, please, Irina. So I'm going to give a brief presentation about the NETFA Leadership Program. Next, please, Irina. I think I'll just jump straight to this. Late last year, we conducted a national consultation. Many of you were part of that consultation, so thank you so much for lending your voices, your experiences, and your expertise on the topic of FGMC during that consultation. This is a mind map that came out of those consultations, which I won't get into the details of it, but basically you can see that there are some groups of information that it's very complex, basically, the situation with FGMC. And you can see across the slide, there's a section in the top left corner, which is about a shared problem of there's diminishing resources, for example, in addressing FGMC in the Australian context. If I jump to the bottom right corner of the white post-it notes there, it says no-go zones. So these are times when people have shared experiences on FGMC that were not very positive, actually, that where they felt like that should not continue. That's a no-go zone. So again, I won't go into much more detail than that, but this is just to give an example of how this consultation directly informed the design of the NETFA Leadership Program. Next, Irina. So then out of that consultation, we designed a 7-month national leadership program, which included 3 forms of knowledge or skills. The first, of course, is knowledge about FGMC from multiple lenses, whether that's the sexual reproductive health lens or human rights lens, gender equality lens, etc. And then the second is structural frameworks. So this is where we took the leadership participants through discussions and presentations about intersectionality, about going beyond cultural competency, just as 2 examples. And these modules were very much informed by the Multicultural Centre for Women's Health PACE leadership program. And then the final part of the leadership program was about strategic storytelling. So this is where we took the women through campaign strategies. So basically, we asked everyone to think about what is your vision for change on the issue of FGMC? What is your theory of change in terms of how you can achieve that vision? And therefore, what role do the stories that you want to tell play within that vision for change? And then we took everyone through specific storytelling skills. Meaning we had a series of video storytelling workshops, and we also had a series of podcast storytelling workshops. Next, Irina. I thought I'd share a little bit about who has been in this program. So just briefly, there were 12 women from around Australia, aged between 20 to 62 years of age at the start of the program. Most states and territories were represented, as you can see on that list there. Some people had experienced FGMC personally, although this was not a requirement to be part of the program. And in fact, we never asked people to reveal personal information like that. And there was a mix of people with formal qualifications and people who had a track record of working with communities. The only criteria really was that you had to come from a community or country where FGMC was practiced. Go ahead, Irina. And there was a whole mix of cultural backgrounds. Briefly speaking, basically we had people from African, Middle Eastern, as well as Asian diaspora in the group. Go ahead, Irina. And in terms of outputs, this is the main thing I wanted to share with all of you to look out for next year. We are currently finalizing 6 podcasts created by these women themselves. And the podcasts have very different angles on FGMC. So we have interviews with community advocates. We have interviews with survivors of FGMC. We also have informative podcasts where it's just the one woman speaking and imparting their knowledge about the impacts of FGMC. We also have an interview with a doctor and a counselor to talk about the mental health impacts of FGMC. And we will be launching this in early 2023, so please look out for that. And we, of course, would love your help to disseminate, to distribute these resources far and wide. We'll also be supporting 2 NETFA leaders to produce 2 video works. At the moment, they are in draft form, so this is an ongoing process at the moment. But just briefly, one of them features an interview with a GP and is aimed at educating healthcare professionals about why it's important to provide quality care for people who have been affected by FGMC, especially pregnant people. And then the second video is an animation that goes through several myths about FGMC and then busting those myths throughout the animation. Next, please, Irina. So that's it from me, everyone. Now, if Patience is here, we are going to hear from one of our leadership participants. We have had a bit of a technical issue, so I'm just going to check in. Patience, can you hear me? Can you say something? No, I don't think she can hear me.
No, okay, I'll give her a call.
Okay. So everyone, maybe whilst Irina is giving patients a call, we're going to try and share a WhatsApp video call so that we can hear from patients. But while she's just doing that, does anyone have any questions so far about the NETFA Leadership Program?
Hi, patients. Can you hear us?
Oh, no.
Can you hear patients?
No. Have you shared your audio as well, Irina?
It's shared.
Oh, okay.
Yeah, I can hear you, but no one else can hear you, patients. That's
Can you stop sharing the
no.
presentation?
Okay, I
See if that
think we
helps.
have some audio difficulties with patients today
Okay.
because I'll just stop share and
Okay.
try to share again. Just give me another chance to try.
Thanks for bearing with
Patients, can
us,
you say
everyone.
something?
No, can't
Can
hear
you hear
her.
patients?
No.
No, patients, no one can hear you. I don't know what's happening.
So how about we try plan B? I'll just call her on the phone and I'll put my phone to my mic and take it from there.
Stop share.
Sorry about this, everyone. Hopefully you can at least hear her. At least you've seen her face for a minute.
No. Okay, I'm sorry. Sorry, everyone. It didn't work. The call didn't work.
Oh, good. It was a good idea, Irina. Hello, patients.
Hello, Rani.
Hello. Can everyone hear patients? Yes. Okay. Great. So, patients, I don't know what's going on, but at least now everyone can hear you. So, do you want to say a quick hello?
Yeah. Hello, my great and honorable NETFA leadership women.
Okay, thank you, patients. So
Yeah.
everyone is very keen to hear from you about your highlight experiences of the program, and everyone can hear you loud and clear. So did you want to share your thoughts?
Yes, please.
Great, go ahead.
My name is Patience Afor. I joined the NETFA Leadership Program through a recommendation of a nurse from ACT Women's Health. I felt very curious learning much about FMGC after the recommendation, and actually, I got my request. I thank the leadership of NETFA for their kind gesture, making it possible to organize such an educative program. Also, for their search to give us such an experienced teacher with much empathy in the person of Rani and her team. Thank you all. I have really learned a lot in this program, ranging from exposing us to each other, which led to making such good friends. From Nanawa country, I have made friends with people at Brisbane, Indonesia, Adelaide, Sydney, to mention a few. I learned how to structure my speech, mostly when interviewing, how to structure storytelling, where to get a link or support when stressed with health conditions. Also to feel the pain and agony of victims of people who are mutilated, as well as understanding my own barrier, on my own boundaries. As as I speak at a level, at the same time, I can speak at the level of each person. Like when I am addressing the secondary school children, the junior ones, I know the languages to use for the juniors, I know the languages to use for the colleges, and I know the languages to use if I am addressing the health officials. I know how to address and at the same time give consent or seek consent before speaking, as well as giving a content warning before addressing them. I also learned much about making a podcast as well as interviewing journalists. Anyway, podcast is what I used for my final assessment. Time will fail me to mention some of my friends' experiences and their gratitude. The group, all my friends, including myself, we are so grateful for what the NETFA Leadership Program did for us. We, that is my friends and I, we are sincerely thanking you all and wish this should continue. Thank you and God bless.
Thank you, Patience. I hope everyone was able to hear that okay. Can I just confirm? Okay, wonderful. Everyone's nodding, Patience. So yeah, well done. Well done in your speech. Do you want to stay with me on this call, Patience?
Yeah, I can stay to the next 20 minutes, please.
Oh, okay. I don't think we have that much time, Patience, but we do have a couple of minutes in case anyone wants to ask any questions. So please just stay with me on this call, and I will ask the group if they have any questions.
No worries, Rani. I am happy to stay.
Thank you so much. So everyone, we just have a couple of minutes in case anyone wants to share anything. And maybe Irina, can we stop sharing the screen so we can just see the room? Great. So Patience, there's about 20 people online who've just been listening to you, and I'll just open up to the group. We have a few people saying, thank you so much, Patience, you are amazing, and thank you, Patience, for sharing. Any questions or comments, everyone? The floor is yours. Oh, and Faye is here and says, sorry, we missed the part with Patience because the connection got lost. Oh no, Faye. Oh, well, we record.
Say hi to Faye for me.
Yeah, she can hear you. She can hear you.
She's a wonderful lady.
Hello, Patience.
Oh, Faye
We're so proud of you.
Faye is saying hello, and we're so proud of you, Patience.
Thank you.
If there's no questions or comments, Auntie Medina says, thanks, Patience. That is great.
Thank Auntie Medina for me. She was the first person that taught me about female mutilation, genital cutting.
Yes, she can hear you, Patience. So I think you just thanked her yourself. So.
All right, Auntie Medina, thank you. You are a lovely mommy. Thank you. God bless you.
Thank you, Patience. All right. Well, look, everyone's sending you lots of love hearts, Patience. Oh, Patience. All right. Okay. Well, Patience, feel free to try and rejoin again because it was lovely to see you, even just for a little bit just then. I don't know if you were able to hear us, but unfortunately we couldn't hear you on Zoom. But you're welcome to try and join again if you can. Oh, there you are. Okay, thank you. Thanks, Patience. I'm going to move us on to the next part of the presentation, unless there's anything else you want to say.
Nothing, only that the NETFA program should be continuous so that we will be improving on what we have done and not to go back. Yeah.
Thank you. Thanks, Patience. We'll see you
my
online
pleasure.
too.
My pleasure. Bye-bye.
Bye. Thanks everyone for bearing with us on that. Oh, the technical issues. Sorry about that, but at least you got to hear her story. And Faye, hopefully you can watch it in the recording. Irina, I think we can continue with the presentation. Great. Okay, so now we have Gianna from TRUE in Queensland. Gianna, are you with us? Yes, I can see you. Great. I will hand it over to you. Thank you.
Thank you very much, Rani. I'd like to acknowledge that we're on Aboriginal land, that of the Turrbal and Yagara people here in Brisbane. It's really nice to see you all, and it was lovely to chat to a few of you, and I hope we get to all chat more. I find this network really helpful. I found it very helpful in the past. Irina, would you mind? I'm just going to show you, I don't have a PowerPoint presentation. I'm going to keep it short and sweet. I would just like to share some of our resources in case they are of use to you or people that you work with. So it may be a little bit small. If you can zoom in at all, Irina, on the left side, that'd be great. So at TRUE Relationships and Reproductive Health, which is the family planning organisation in Queensland, we have a small sexual and reproductive health project that centres people from migrant and refugee background. And FGMC is just one part of the larger sexual and reproductive health picture. So please have a look at our website for other resources if you work in reproductive and sexual health. For FGMC, we have a short online self-paced course that is meant to be introductory. So that's accessible to anybody. You just have to have an email really to log in. And we are in the process of developing one that is centred for GPs. So this one is for health professionals, but it can include interpreters, community workers as well. And the one we are developing for GPs is meant to go in a little bit more detail. And if you just go back, Irina, we have a fact sheet. This is helpful, but more helpful if you are in Queensland. So it's just a double-sided A4, so 4 pages. And it just has a snapshot of what FGMC is, language, recommendations for working with people who have experienced FGMC. And the last page is really Queensland relevant with Queensland referral pathways. And the other thing is just sharing some podcasts. So if, Irina, you go back to the page, on the same page, which we can share later, I'm sure, there are links to 2 podcasts. And one is from a clinical perspective from Melbourne service. So thank you for being involved with that. And the other is just stories. So the first one is more of a health perspective, and the second one is women sharing their stories about FGMC. So I really look forward to the other podcasts that come out. I think it's really great to share these resources and anything that is helpful in this area. Most of our work is with health professionals, community workers, and interpreters and translators, but we can also respond to community need if that's there. So I'll put my email and that website in the chat, but really just wanting to reach out and connect to others and share resources. All of these are fully accessible online. So thank you very much, and I look forward to all of your presentations.
Thank you so much, Gianna, for sharing about those resources. Irina will bring up the next speaker, which is Dr. Ngatho Samuel Mugo. Ngatho, are you there with us?
Yes,
you are.
I'm there.
Great.
Yeah.
Over to you.
Thank you so much, Rani, and thank you everybody for having me today. So today I would like to share a little bit of what we are doing in New South Wales as the FGM program, which is a statewide program. And today I will just be focusing on the community education program approach for a project or formative research that we are doing at the moment is called Make Your Voice Heard. So before I would go ahead, I guess I would like really to acknowledge and thank the Multicultural Health Service Manager, Monica Latene, and also the statewide and specialized program team leader, and also the FGM program manager, Dipti Zachariah, for their endless support, because without their help, we wouldn't be able to reach to make your voice heard. So today, Make Your Voice Heard is a formative research project that aims to understand the cultural perspective and experience of female genital cutting across among a diverse community across New South Wales. And we the project is initiated by myself and Dipti, also in collaboration with Dr. Niloy, he's an anthropologist, Professor Michael Dibley, statistic, and Associate Professor Olayide, who's here also with us today. So it's for the collaboration work between Western Sydney Local Health District, Southwest Sydney University, and Western Sydney University as well. Next slide, please. And because our program or FGM program is statewide program, we thought it would be essential also to include other collaborator across other 4 local health districts from South Western Sydney, South Eastern Sydney, Nepean Blue Mountain, and Hampton, New England. But I would like to highlight also the importance of having our bilingual community educator, who are they are community leaders, but also subcontractor staff working with the FGM program. So we have our lovely, so the person holding mic is Jujet. She's from Sudan. And we also on the right side, we have Fozia. I would like to highlight them, and also Andy from Indonesia. So these are they are trained bilingual community educators who have helped us to conduct the survey. We have trained them also to conduct the in-depth and survey as well. Next slide, please. As the FGM program, we wanted to redefine our approaches, and we thought it's important and essential for us to go back to hear from the community, wanted to understand what are the existing needs, what are the barriers, how can we help them, and even how can we modify our approaches also to relevant to existing need of the community. So this is a survey and in-depth interview study that aim to understand and explore community perception, view, and opinion about the existing practice. We also wanted to know about the community perception, view, and opinion about the laws banning FGM in New South Wales, but also what can we do as a program also to help the community as well. We wanted to hear from the women and girls who are affected by the FGM, what kind of challenge and barrier they are facing, but also we wanted to understand those who worked in the service provider who work with the community from high-risk practice in the community. So what kind of the barriers they're facing to provide support to these women. Next slide, please. So our study sitting, we selected 5 local health districts across New South Wales with the highest number of community from the high-risk practice in the community. So we had Western Sydney Local Health District, South Western Sydney, South Eastern, Nepean Blue Mountain, and Hampton, New England, for us to be able to get the mix from the participants. Thank you. Next slide, please. So in order for us to capture a broad community perception, view, and experience on the FGM practice and all the information related to existing FGM program approach, we wanted to include a wider range of the community for us to be able to get appropriate response. So we included mothers with genital cutting experience, age 18 and over, and also wanted to hear from husband as well, their perception and their experience also related to having a wife who had FGM. We wanted to also wanted to hear from the young people who might be born here, also what is their view with regard to FGM, whether they have changed or they're still holding into the tradition also. And we wanted to hear also from those who are influentials in community leaders and community leaders, as well as the service provider as well. So these are the targeted study participants that we wanted to reach out to them to hear about their experiences as well. Thank you. Next slide, please, Rani. Yeah. So our approach or design was a mixed method approach. So we have a structured survey questionnaire, and we have adopted UNICEF survey, And the structures survey is targeting, we have a specific questionnaire targeting women with FGM. And also if a mother have a daughter who's under 17 years old who have had also FGM as well. And we have a specific question around perception and view targeting men as well, and overall questionnaire for young adults 18 and above. And as the initial design of the survey was meant to be conducted online, and we had a specific QR code for each of our bilingual community educators that they're able to share it with the community, with the networking as well. And we understand also with some of our community that might be illiterate. So we have a language support that our bilingual community educators are able to arrange the time, and they're able to walk the community through the questionnaire, through face-to-face or even by calling them and for them to be able. So we wanted also to include even those who are illiterate in the mix as well. And we have another survey targeting religious and community leaders, community workers, allied health workers, and service providers as well. Next slide, please. So the first one is mostly to help us to get the data, but it was also essential for us to be able to understand the why and the how and the what. And this is only we can answer it through doing an in-depth interview with women who had had FGM experience, also with the husband, as well as with the key informative interview with our bilingual community educators, because they've been working in our program for quite some time. So reaching out to them is really essential for them for us to understand what kind of the barrier they are facing to facilitate education to the communities, and how can we also help them as well. So the in-depth interview is the phase 2 of the formative research, and it could be scheduled either online via Zoom or even face-to-face with the participant.
Excuse me, Ngatho. This is your 2-minute
Okay,
warning.
thank you. Almost, okay, thank you. Next slide, please. I'll quickly go through some of the approaches that we have used with to conduct the data. So we sent direct emails to some of to service providers. We're using our networking. And also we called schools as well, and we send them also emails. We have used every single opportunity, such as during the team African leaders meetings. And up to now, we have about 108 survey completed. Next slide, please. So this is just to give us the number of complete survey per service providers and religious community leaders. So we started the survey was open from February up to August, and we have about, our expected number was 300, but at the moment we were able to get response from 108. Next slide, please. So the phase 1 of the survey was with the service providers, but we also had with the communities, and we have to model and change our approach also to reaching to our communities. And now at the moment we had about 361 participants who completed survey from the community. And we have used every opportunity. For example, during Sudanese Women Health Forum, we were able to collect some data from the community. During the Indonesian Health Forum as well, we were able to. So the majority, 37% of the complete survey were during the community event. Our bilingual community educators, they did excellent work. They also did door-to-door survey drop-off and pick-up as well. And some of them did it during the women's support group as well. Next slide, please. So this is just to give us an overview of the number of completed survey per the ethnics group. So we, and it's ranged between 100 to 8. This is just based on for some ethnic group, we have more bilingual community educators than the others. And we were able to reach some community even during the Father's Days. Recently, we were able to collect some data. Next slide, please. So we are in the second phase now, and we just started with the in-depth interview. So this is just the number that we have completed, 7 from the BCE and 4 from the community. Next slide, please. So I just want to say thank you for having us, and I would like to acknowledge everyone who helped and promote the survey. and also Ladia Farak, who helped us to translate the questionnaire to Arabic as well. Thank you for having me today. Thanks. And this is just our details. If you have any more information, you can reach out either to me, myself, or Dipti Zakaria, which is the team leader, which is the FGM program manager for New South Wales program. Thank you.
Thank you. Thank you so much, Ngat, and apologies for, interrupting you during your presentation. And thank you so much for keeping to time. We really appreciate it. So everyone, we do have 5 minutes break now, just to have a stretch, grab a drink, whatever you need. And we'll come back in 5 minutes. And I think Irina will play a bit of music. And when she turns it down, that's the cue to come back, everyone. So thank you. Have a good break. We'll see you in a few minutes. So start coming back, everyone. And I would like to check that Monica and Angela are with us. Please, I can see you, Angela.
Yeah.
Great. Wonderful. So if everyone can please either turn on your cameras or put in the chat that you're back so that we know that we're okay to start again. Oh, wonderful. Okay. I think most people are here, Angela and Monica. Did you want to start off on your presentation?
Yeah, thanks, Rani. Can you all hear me
No
okay?
worries. Yeah, loud and clear.
Great. All right. Before I start, I'd just like to acknowledge that Monica and I are presenting today from Ghana land in South Australia, and I'd like to pay my respects to elders past, present and emerging. So my name is Angela Brown. I am working with Monica on her project, and Monica is a really experienced clinical nurse and midwife. She's done a Churchill Fellowship in FGMC, and she's been working on her doctoral studies to explore the effects of to explore the experiences of women who have accessed health services in South Australia that have experienced FGMC, with a view to develop an education package for health professionals that is informed by women's experiences and needs and wants. So she's actually going to talk you through some of that work that she's done when she's been out in the community talking with women. So over to you. I'll put our contacts in the chat box as well, but over to you, Monica.
Thank you, Angela. Can we have the next slide, please? Sorry. So as Angela said, we're working on this project, and I just wanted to give you a little bit of background of how it started. So from our research, we know that global migration has seen the practice of FGMC rise around the world, especially in countries where FGMC is illegal and not part of the cultural norms, such as here in Australia. Next slide, please. It is estimated that there are 200 million women and girls that have FGMC around the world, but we don't have accurate estimates of what we have here in Australia. But NGOs working with culturally and linguistically diverse communities have anecdotally reported that 6 out of 8 women from FGMC practicing communities have FGMC and are actually living here in South Australia. So for us, that was like a big number. And then we looked at, well, what are we doing in clinical practice to support these women and their needs? Next slide, please. So just a bit of a content warning. I will be sharing statistics to do with death rates among babies from parents affected by FGMC. So if you need to take time out, please do so now. Next slide. FGMC can cause significant immediate and lifelong biopsychosocial implications for girls and women, and these can be exacerbated or made worse during pregnancy and childbirth. So healthcare professionals are really in an ideal position to treat women, to support them and to be able to identify their needs and ensure that the risks are reduced. especially during childbirth. But there are several studies that have identified that healthcare professionals do not have the necessary knowledge and skills to identify, manage, and support the complex needs of women, and in particularly because there aren't enough education, modules or education being provided directly to clinicians. Next slide, please. So I designed a protocol to do a study here in South Australia, looking at how we can improve the knowledge, confidence and skills of healthcare professionals to meet the needs of women with FGMC in a culturally safe manner. But by incorporating the voices of women, we were very specific that we wanted this to be about women telling us what we need to do to ensure that they have the best care available. Next slide, please. So what we wanted to know was what factors affected the experiences of women with FGMC accessing health services here in South Australia, what were their health needs, and what impact does this education have on the knowledge, attitude and practices of midwives and nurses. Next slide. I designed a 3-phase project where in the first phase we did an exploration of talk to women about their needs and what they wanted to see. Phase 2, which we're just finalizing now, is the development of an education module with the information that the women provided for us and their advice from a cultural working group. And then phase 3, which will happen early next year, will be the actual evaluation of the program. Next slide. Thank you. So phase 1, I set out to answer 2 questions. We wanted to know what factors affect the experiences of women with FGMC accessing health services and what were their needs. Next slide, please. With the help of a community cultural advisory group, members of FGMC practicing communities, including women with FGMC, and FGMC health experts from Refugee Health Service here in South Australia, we recruited and interviewed 10 women with FGMC from 5 different countries and conducted what is known as a reflexive thematic analysis to identify the themes of these discussions. The beauty of what I think is a strength of our project, of our findings, is that we were able to get women from various countries, which is often not seen in research. Most of the research that we have looked at, that have interviewed women, focuses on specific regions, whereas ours is quite broad. The other thing that's also a strength was that we were able to have interpreters available for women. So women who wanted to be interviewed and that didn't speak or understand English could have access to it. And I think that's an area that is normally missed. Not many, not many women who don't speak a country's language can participate. And I think for us, that was really important and essential. Next slide, please. So we looked at the interviews and we identified key areas that women were saying, this is what needs to happen and this is what our experiences are. Next slide, please. So the first theme, we called it the healthcare experience. Overall, most women interviewed described positive experiences with healthcare services. They felt that healthcare providers treated them well, with respect, and gave them sufficient information about their care. Women expressed complete trust in doctors because they were the experts, but they also identified some areas that needed improvement, including communications, such as access to the right interpreters, which was something that we hadn't considered because women were saying, we speak Arabic, for example, but there's different dialects around that language. And so that we found that quite interesting. Having more time.
Monica, this is your
Yes.
2-minute
Sure. Having more time during clinical appointments, more opportunities for continuing of care, and the inclusion of family in some aspects of care and treatment decisions. Next slide, please. Understanding cultural traditions was another one, and that was sort of like the strongest one. We found that upholding cultural traditions was a significant determinant of the healthcare seeking behaviours of women, and several women conveyed strong connections to the culture and a need to maintain these traditions, especially those pertaining to pregnancy and childbirth. Next slide, please. Speaking up about FGMC, we didn't actually ask women about their FGMC experiences, but many felt that it was necessary to talk about it. So they told us about their knowledge, what it meant to them. Some of them didn't know they had been cut. They also spoke about an unwanted tradition and feeling relieved that their daughters were safe here in Australia. Next slide, please. And women wanted to let us know that they wanted to work together with healthcare providers to improve their experiences. They wanted to partner with healthcare services in designing and implementation of cultural education, facilitating access to female healthcare professionals, and also female community health workers. And they wanted to be involved in their care and healthcare plans. Next slide. So what's next? We have now finished creating the module, which we use the information that women informed us in phase 1, and now we'll be piloting it with a view to evaluate it early next year. Next slide, please. And that's the evaluation. Next slide. And that's it. We would like to thank all the women who volunteered to participate in our project and trust us with their stories. And we also like to thank the advisory group set up with members from FGMC practicing communities and Refugee Health Service here in South Australia. Thank you.
Thank you, Monica and Angela, for that really, really insightful presentation. So everyone, if you have had any questions so far, keep them, write them down or what have you, because we will have 5 minutes at the end of all the presentations to ask the presenters your questions. Irina, let's keep going. So next we have a presentation by Associate Professor Olayide Ogunsiji. Are you with us? Yes.
Yes, I am.
Okay, over to you.
Okay, thank you so much for giving me the opportunity, and I would like to acknowledge the traditional owners of the land where I am. That is the Darug land in Sydney here. I'm presenting on behalf of my team from Western Sydney University, but I've got Adis Cole, who is based in Queensland. She's actually been very active in working together with health providers and educators in Queensland, because there is a growing number of people living with FGMC there. So thank you so much, Adis. She's on here with me this afternoon. And Fatu, she has been part of the previous session like this. She's a strong advocate, and we are working together in the space of Female Genital Mutilation Awareness Australia, FGMAA. So I acknowledge them for being here this afternoon. Next, please. Pretty much the information that we already know, but I feel I should provide this background, and some of us have already provided some information along this area. But what is very important to me is that beyond the statistics that we have got here is the fact that if nothing is done by the year 2030, which is just about 8 years' time, about 5 million girls will be at risk annually. And in Australia, we know that from the latest report from Australian Institute of Health and Welfare, about 53,000 women and girls living with FGMC are living in Australia, suggesting a huge need for for this to receive adequate and optimal health care. Thank you. Next one, please. So what is going to be the aim of my presentation this afternoon is just to share recent work that we have on female genital mutilation or cutting. Some of the work that have been done before are not part of what I'm presenting here, but the latest one that I think a number of us here will be interested in knowing. Next slide, please. So pretty much I'll be talking to the recent research which focused on work with professional, with primary healthcare providers. I'll be talking to the area of how we found the Female Genital Mutilation Awareness Australia FGMAA, and also the Virtual International Day of Zero Tolerance virtual event that we held this year. Next slide, please. So looking at the research, empirical research among primary healthcare professionals, about 21 primary healthcare professionals in New South Wales took part in this study. And by primary healthcare professionals, I'm talking about women's health nurses, counselors, psychologists, GP, women's health, members of GP clinic, and also those that are having direct contact in providing psychological and psycho-emotional health care to women living with FGMC. So they took part in interview, face-to-face interviews between in the year 2021. And what we found pretty much from these primary healthcare providers is the fact that we have women living with FGMC that are presenting to Women's Health Center, GP clinics, and primary healthcare centers. But despite the fact that we are having an increasing number of women presenting to those primary healthcare centers, there is limited knowledge of these workers in providing care for the women that are living with FGMC. And so what we find out is the fact that the women that are presenting for care, there is limited trust in these healthcare providers, with the assumption that they do not understand what they are presented with. So there is lack of trust, there is lack of willingness to communicate with healthcare providers, and there is gross need for primary healthcare providers to be informed in order to provide optimal health care for these women. And one publication is already out from this study, and there are 2 others in the pipeline. I'm happy to share it, or you can just follow the link from what I'm sharing on the screen today. Next slide, please. So the next thing in terms of what I intend to present today is the founding of Female Genital Mutilation Awareness Australia. So myself and the 2 wonderful women that I acknowledged at the beginning of my presentation, that is Adis. Okay, that is Adis and Fatu. We came together in terms of the need to further raise awareness in this area, pretty much because of the lack of awareness among a growing number of healthcare providers that receive their training in Australia. And we felt that there is need to raise awareness among healthcare providers and even among women that are living with FGMC. A number of them are living with the FGMC and they may not be aware, especially if they have type 1 done on them. And beyond the criminality, beyond the illegal status of FGMC in Australia, we wanted to partner with them to know that they have a voice and they have a role to play in discontinuing the practice in Australia and beyond. So our vision is what I've got on the screen there, and mission as well. And we have been working in the area of developing resources to support our work in this area. And I'm so glad that we're having this session this afternoon, because there is a lot of potential not to reject the will, but to work in partnership with those that are already developing resources. Next slide, please. So the next thing on the plan that I have is to share the 2022 Virtual International Day of Zero Tolerance that we held in February this year. It was actually intended to be delivered in partnership between New South Wales and Queensland, because that is where I am based in New South Wales, and Adis is based in Queensland. And so we intended participants between these two states. However, it turned out to be an international event with some attendees from United States of America. It was attended by frontline health providers, multicultural health service providers, and Western Sydney University staff. And we have speakers that were drawn among them were survivors, advocates, researchers, and service providers. And important thing that came out from that zero tolerance event, virtual event, is the unmet needs of women and girls that are living with FGMC. And we got a great insight of the fact that COVID-19 actually set a number of countries behind in terms of their advocacy and in terms of the United Nations achieving the SDG goal 5.3. So the work continues. So it is intended to be an annual event. Next slide, please.
Olayide, apologies, this is your 2-minute warning.
Thank you. So that particular event is meant to be an annual one. Part of the work that we are doing in the space of FGMC has actually been showcased, and I provide the link to that flagship magazine, which is accessible to the public from Western Sydney University website. So the link is to that magazine if you would like to read more, and that is me together with Adiz that is being you are seeing on the screen. The next slide, please. So in terms of the way forward, we intend to make the International Day of Zero Tolerance an annual event, and we have started in the background to prepare for that of next year. And we also intend to continue to work together with the women living with FGMC and healthcare providers. And of course, there is a lot of potentials drawn from all the resources that we have here this afternoon, and ongoing awareness and supporting advocacy work in that area within Australia and beyond. Next slide, please. All right, thank you. That's it from me. Thank you.
Thank you so much, Olayide. It's been wonderful learning more about the work of FGMAA. Yeah, I'm really also very happy to make the connection with you today. So next we have a presentation by Catherine. Catherine, are you with us? Catherine's midwife and advocate, and yes, I can see you now. And Catherine, I'm so sorry, I didn't get a chance to check with you about how to pronounce your last name. Do you mind just telling me how to pronounce your last name?
That's okay, Rani. Hi, everyone.
Oh, is it Catherine Sesay? Is that?
Yeah, it's Catherine Sesay.
Yes, okay, wonderful. Over to you, Catherine. So all we've done is given you this title page, but then the rest of your presentation is the same, and you will have the next 10 minutes. Oh, and I'll give you a 2-minute warning as well. Thank you.
Hi again, everyone. I just want to say a big thank you to NETFA for the opportunity. I'm really grateful and honored. So, as you all know, I'm Kathleen. I work at Westmead Hospital as a midwife, and so I don't want to go deep into to give a background of myself, but I just want to go straight to the slide, and then I can just talk about myself a little bit. Okay, these are just the contents of what I'm going to talk about because I haven't got enough time. So we'll go to the next slide, please. So what is FGM? So I'm quite sure most of all here know what FGM is all about. So the 4 different types, I just don't want to go into that, but I'm quite sure we all expertise in these settings. So, and we know what FGM is and the different types. But I'm going to go into it, sorry, just trying to. Sorry.
And for a bit of context, Catherine, some of the other presenters have already touched on the different types and
Yeah,
things.
that's why I just don't want to go into it because I knew, like, you know, we've all got a knowledge about it. But I'll just go to the next slide, please. Okay, my personal experience and reason for being an FGM advocate or activist. So, sorry, I just came back from work. I'm just trying to, you know, get myself around.
It's all good. It's all good. Thank you for being here.
So now I do believe that the reason why I wanted to do this is to make a change and be part of this great team that are, you know, trying in diverse ways to put an end to this cruel act. And also, I do believe that every girl or woman deserves a better life, and they need to consent into anything that is any procedure that needs to be done to them. And also, I do believe that they don't need to live in fear because the in reference to this act that is being done to them, so many women are in fear because they don't want to talk about it, or they can't make a decision because of pressure from the family members or partners or husband or community. So they don't need to live in fear. And also, I don't want them to face the challenges so many of them are facing in the community. And I do believe that girls should be protected and should be given the life that every mother, girl, or woman deserves. Okay. And regarding the personal experience, like I'm from an African background, Sierra Leone to be precise. I should have been a victim, but I was fortunate to be saved by my grandmother. So, but I've got close family members that went through this, and I've seen the psychological and emotional impact it has on them. And it's not just family members, and also community members as well, here and back home. And I've seen what they've gone through. So that's why I liaise I volunteered to be part of a group in the UK, you know, just to work hand in hand with them to put an end to this. Because I think this needs to stop because it's not good. And also being a midwife, I've seen a lot, and I don't want anyone to go through this. And it's very hard being a midwife and looking after a victim that is from an African descent. Some of them don't feel comfortable, you know, because of stigmatization. Oh, I know her, she might gonna, you know, tell people in the community about this. So it's really hard. So I had a big thought about it, and I'm like, no, I need to be part of this group. I need to be part of the people that wanted to make a difference in so many people's lives. So that's why I volunteered, and I'm glad for Auntie Juliana to join me in the NETFA group, and I just want to make a difference. So, and I'm working on it, and I've got Auntie Olayide there, you know. So we're all working together, you know, to put an end to this. So yes, next slide, please. Now, as I was saying before, most of these women, because of the complications that they go through, as a midwife, it's very hard, and not just as a midwife, and also as a woman, because for them to go through pain, urinary issues like incontinence, they can't control their bladder, and also bleeding, of course, and infection, because some of these items they're not even sterilized, and they've been used on these girls and women. So, and also delay in wound healing. And that's why we find it very hard when it comes to de-infibulation, because it's so hard to go to redo the procedure. It's very difficult, and some women don't want to go through this. So that's why most of them end up having cesarean section, because they don't want to go through the whole procedure again. And also most of them are in shock. and especially, what they're going through. Like, and also, let's say, for example, if they presented to birth units and they've been told, oh, we need to do such and such, or these are the complications you're going to go through. They're in shock because they're not thinking about, they never thought like that, the tiny procedure that was done to them a couple of years back that is going to, affect them, in diverse ways, and also, or has a great impact on them. They never thought about it. So it's really hard. And also it can also cause death because infection can lead to death. So it's really hard. And these are the short-term complications. And the long-term complications are, next slide, please.
Catherine.
As I said before, urinary tract infection, they have painful.
Catherine.
They have, when they pass in urine, it's very painful for them. And I've also talked about vaginal infection, which can be long-term as well, and infertility.
Catherine, sorry, this is your 2-minute warning.
My volume is really low.
Oh, okay. You have 2 more minutes. Can I make a suggestion? Because you only have 2 more minutes, is it okay if we skip a couple of slides to go straight to the 4 steps process? But that's only if you're okay with that. Yeah. Okay.
Sure. As I said, let me just continue regarding the long term. So there's so many complications involved in this, and bleeding, poor obstetric outcomes. And next slide, please. Sorry, I'm just gonna, because I haven't got enough time. So now, where is FGM most prevalent? We all know it's more prevalent in Africa, the Middle East, and Asia. Next slide, please. Now, addressing the FGM. Sorry, I haven't got enough time. So as soon as the woman presented to us, what we do is to welcome them in an approachable way. These are strategies that we need to put in place in fixing this issue. And we asked about their status, which is very, very important. We need to gather the history, once confirmed. Another thing that I want to say regarding that, not every woman will disclose that they've had FGM before. They don't do it. The only time that we will pick it up is when we do vaginal examination. So that's another thing to take note of. So things can be missed at booking in. And so at once we pick that up, we need to assess if the woman has support regarding that, and also the reasons and thoughts and opinions regarding that, and also if the woman thinks that FGM should stop, provide positive reinforcement, ask if she thinks it might be difficult keeping a position towards ending FGM. So we need to, explore, explore as much as we can regarding what the woman is surrounded with. We need to gather as much information, please, and also ensure that she can come back for support. That's very important because we need to follow up, because sometimes things get missed. And especially if she, let's say, for example, if she had a female child, and we're not sure what their plan is, what, their cultural, practices, maybe every female has to have it. Like for me, yes, that was one of the practices, but I was lucky, as I said earlier, because of my grandmother. But if they're planning to take the female child back home, we need to stop that. We need to get a community nurse or midwife to follow up, make sure that is not done. And also in terms of belief, sorry, I just need to bring that down. And also in terms of belief, I need to explore that as well, invite the woman to rethink the aspect of FGM and she thinks it's positive, consider and contrasting our beliefs or reason for supporting FGM with facts about procedure, including long-term consequences or complications, and also ask the woman how she feels about this. Next slide, please. And also in terms of change, we need to encourage the women to reflect on change by highlighting that it's possible to change traditions, encourage the woman to think about what she has been discussed, and highlight the role of healthcare professionals is to end FGM practice. And that's why we're all here and discussing this side, encourage the woman to discuss ending FGM with persons from a community who she trusts. And also we need to document the key findings. So whatever information we've gathered from the woman, we need to document it and then put follow-up plans in place. And in terms of closure, we need to ensure women have understood the discussion regarding FGM, address any questions or concern that the woman has raised, connect the victims, and ensure referrals to support groups and also follow-up plans in place, as I said earlier. So in the initial stage during booking in, because some of the women, they are from non-English speaking background, so we normally use pictures showing the different stages so that they can easily identify what procedure has been done to them or what stage has been done to them. Next slide, please.
Catherine, I'm really sorry, but I think we'll need you to wrap up. And I just want to reassure you, this is not the only opportunity you'll have to connect with our colleagues across Australia. With everyone's consent, I'd love to share the presenters, all the presenters' slides with this group. Please let me know if you don't consent to that. You can private message me in the chat, but that's another way that people can read your materials as well, Catherine. But is it okay? Would you mind wrapping up, I don't know, in the next like 30 seconds or so? Because then we want to open up for discussion with the group.
Sure. I'm so sorry, everyone. I've got my, it's very hard for me to compress everything in 10 minutes. Yeah. So maybe next time, if I have enough time, I'll try to go through all my slides.
Thank you.
So in a nutshell, what I will say, as midwives, thanks for that, Brie. What I wanted to say in terms of the healthcare professionals education consideration, it is shown that midwives and nurses have not been properly equipped to substantially and effectively support women with FGM, and that was evident from Auntie Olayide's presentation. Since they have, I think that's okay. Since they have not had the full experience due to lack of educational opportunities, it is also evident that some midwives and nurses do not have information that they need the clinical skills and cultural competence, confidence, and awareness of legal responsibilities to effectively support women with FGM. Next slide, please. Sorry, the volume is really low. All right, strategies for healthcare professionals. Providing effective communication with the patient. This is really essential, both verbal and non-verbal. Ideally, we need to do it face-to-face, and we need to be sensitive, empathetic, and non-judgmental. And the second one is patient-centered communication. We need to think about their values and cultural beliefs, their understanding of the practice of FGM, their understanding of the complications, their medical needs, the expectations involving patients in their management. That is very, very important. So whatever thing we're doing, we need to make sure we involve the patient and also share decision making. So it's not just us, it's a teamwork. So it's a whole team of multidisciplinary, so that will come together, to talk about this, because we need next slide, please. We need a social worker, we need a consultant, we need a midwife, we need a nurse, we need an interpreter. Sorry, next slide, please.
I'm really sorry. I don't enjoy interrupting you at all, but I need to make sure we have some time for a group discussion.
That's okay. That's all right. Maybe next time. That's okay.
Yeah, I'm fine with that. Okay, I'm very sorry about that, Catherine.
That's okay.
Thank you so much for the work
That's
you
all right.
put in. We really, really appreciate it. Irina, I think let's stop sharing screen just for the next few minutes whilst we do a Q&A. Firstly, I want to give a round of applause to all the speakers. We've obviously, people have shared so much of their expertise and their knowledge. So firstly, a round of applause. For anyone who joined us a bit late, we've had a whole lineup of speakers. So we have heard from myself and patients about the NETFA Leadership Program. Then we heard from Gianna from TRUE in Queensland about some of their FGMC resources. Then we heard from Dr. Ngatho Samuel Mugo about their research project at New South Wales Health. And then we heard from Monica Diaz and Angela Brown from the University of South Australia, also about their research process and project. And we heard from Associate Professor Olayide Ogunsiji about FGM-AA. And then finally, we heard from Catherine from her perspective as a midwife. So I just want to open up just for a couple of minutes for any questions or comments or reflections from the group. Do you have any questions for any of the presenters? Parisa, yes, I can see your hand, sorry. Go ahead.
Hi, everyone. Sorry, I had to go away for a minute. Yeah, I have, I think, a whole bunch of questions, but one of my questions was, how do we know, I think one of the presenters talked about at-risk communities, or maybe all of you did. So I was just wondering, how do we know which are the at-risk communities? Like, how do we know? Yeah, again, yeah.
Thank you. Would any one of our presenters like to respond to that?
Go.
Yes, go ahead.
Thank you for that question, Parisa. Starting with communities that have been reported of having, it's in the literature. If you look at, World Health Organization website, there are a list of countries where studies have been done, and then we know that they have had, it's a country of the world where it is prevalent. But having said that, it doesn't mean that every single individual that have come from those parts of the world have had it done. It's just a matter of being aware of what the literature is saying, and which then means those communities have the tendency of having it done. And we know since the early 90s, where the global community have actually been directing attention to it, the incidence rate is reducing. But then, even up to today, we know some countries of the world where girls, at least about 90 to 95% of girls from those communities have had it done. So we tend to look at the statistics in that area. And I guess pretty much the way to be culturally sensitive about it is to know how to ask questions about whether people that are presented for care have had it done. That is another area of communicating it, being culturally sensitive in asking the question and being respectful of people from those communities.
Yeah, thank you so much. And sorry, I don't know how to pronounce your name.
Olayide.
Olayide, thank you, Olayide, so much. Rani, can I ask another question?
Maybe just pause in case, thanks,
Okay.
Parisa.
Yeah,
Is
no
there
problem.
anyone else who would like to ask a question or make a comment? No? Okay, yeah, go ahead, Parisa. Yeah.
Okay, so the service provider that many presenters refer to means hospital. Who are service providers? I know some of the questions is like, but yeah, just learning here. So who is a service provider when it comes to women who have experienced FGMC?
I think it depends on what context you're looking at. So a service provider is anyone who gives some kind of service. So I'm in healthcare, so it would be nurses, midwives, doctors, but you also have social workers and counselors and bicultural healthcare workers and different people. So it depends on what service they are providing, like what their background is.
Okay, cool. Got it.
And I think it's also include the schools as well.
Oh, schools.
The girls that are living with it, yeah.
Yeah, cool. I do have more questions, but
That's great. Good on you, Parisa. Hang on, just before you go through your list, is there anyone else who would like to make a comment or a question? I'm aware we have colleagues from all around Australia, so I just want to make sure. No, we're okay. Okay.
I'm gonna ask away.
Go ahead. Go away. I'm not go away. Go ahead.
So which presentation was it? The one that talking about who was surveyed and who we interviewed and stuff. Has there ever been interviews in, and this is like a very general question, has there ever been interviews with people who perform FGMC to, I don't know, to involve them, engage them in creating the change? Does that make sense?
Yeah, that's a great question.
I mean, it's good because I think it was in Catherine's presentation, like the 4 steps. The third one was change. And I felt like, okay, these women have experienced FGMC, but then we are making the agents of the change as well. Like we're putting the kind of work on them as well. I mean, it's good to involve them, of course, because they are in the community. I mean, we want their voice to be heard. We wanted them to have their voice and all of it. Like, I get the point, but I'm like, is there a point to include those who perform it in the change?
I think Olayide, you wanted to respond to this? Go ahead.
Yeah, well, thank you so much for that thought-provoking question, Parisa. It is a criminal offense to have it done in Australia.
Yes.
And as a result, it is mandatory reporting if you have somebody to say that he or she is having it done. However, there are some cases in court now of people that have had it done on daughters on Australian soil. But it's a very good question, especially for researchers in Australia to reach out to outside Australia, especially in the global attempt to address this issue, which is a global issue. It is a global issue because I think when Monica was presenting, she said about 92 countries in the world have had it been done. And apart from that, United Nations Sustainable Development Goal have it as part of the cultural practices that need to be eradicated by the year 2030. So it means it is a global health issue. So I guess part of what this collaboration can think about with regards to where to from here is for the bunch of people that are working in this space here to consider even reaching out outside Australia, perhaps engaging people that are practicing it and find out about what are their motivation for having it done.
Yeah, that's the kind of thing I was thinking about. Yeah. Is it only criminal in Australia? No.
It is not only in Australia, it is a criminal offense.
If we reach out to them in other countries and talk with them, then yeah, I guess we don't arrest them or whatever because they are not here, but that we still can talk with them and get that side of their ideas and try to, especially if I think one of the presenters say sometimes like families who are in Australia, like take the child back to their country or somewhere in another country to perform it, then I guess.
Which is still illegal.
Yeah, I know, but I guess, that means maybe there is a bit of work to do around looking at it in a more from a more international perspective and include those outside. Because I just it's like these women have
Parisa
expressed this, but wait, hang a minute, I'm gonna finish my sentence.
Okay.
But then it's like the work to create the change is also on them. I don't know how I feel about it.
Yeah.
I do have one more question, but I'm guessing it's a no.
Sorry, no. I thanks everyone. Honestly, I don't enjoy being the timekeeper here. And sorry, Monica. Maybe you can respond in the chat to Parissa's question. I wanted to make sure that we had a few minutes as a group. Irina, do you mind bringing up that slide about the question I wanted to ask everyone? So I wanted to ask all of you, and I think our conversation is starting to head in this direction anyway. What do you think is the most important and urgent problem that we need to address as a national network in 2023? So thinking really quite immediate, right? Because 2023 is only a couple of months away, or even 1 month away. So I wanted to ask this group, what is your response to this question? And again, we don't have to resolve this today. I just wanted to spend a few minutes listening to your diverse perspectives on this issue, on the issue of FGMC. So this question, by the way, came about because I've been receiving some queries or requests. Some of them have like shared concerns. So for example, I hear from a few midwives who have asked me whether there's a national guideline for the management of FGMC for maternity services. So obviously that's a really urgent thing, I think, from the perspective of midwives and maternal service providers. What do you think? What do you think is the most excuse me, the most urgent work that we could all be doing here as a national network? Feel free to either put up your hand and speak, or you can put it in the chat.
I think definitely working in clinical practice as a midwife, like that's definitely a thing that we need a standardized procedure or guideline around it. And hearing all the work that's been done nationally through this forum, there's like a really good potential to be able to create a document to guide that. I traveled overseas a few years ago through a Churchill Fellowship where I actually looked at this, and the UK has a fantastic model around this, and they have very clear guidelines, very clear pathways. And I think knowing that it's all standardized, it will make life a bit easier. But in conjunction with that, we definitely still need to ensure that the education is in place, that the communities are being educated, and that clinicians have that background, because there's no point putting guidelines and people go, well, I don't know what to say, I don't know how to talk about this. So I think it's a joint thing that needs to be happening.
That's really wonderful. Thank you so much, Monica, for sharing your experiences. I'll go to Bree and then Gianna.
Yeah, I just kind of wanted to echo what Monica was saying, and particularly in places like we're here in Darwin. And so while I was saying some in our breakout room, we have a quote unquote, sizable population from communities at risk, but that's in a Darwin context, which our whole community is very small. So the actual exposure and cases that are going through the system at any given time are going to be quite small. And so I think that the education is really, really important, but the standardized guideline is so good for those who, may see this once or, once a year, once every 2 years, but still had something to refer to be like, oh yeah, what am I supposed to do about this again? How does this work? And having those standardized guidelines, I think, really helps that kind of thing, and like more like regional and rural areas like ours that don't have such a consistent exposure to sort of develop that knowledge base.
Great, wonderful to hear your perspective on this. Gianna, go ahead.
I agree, national guidelines, but also, in Queensland, there are very limited referral pathways as well. So, knowing people that go from here to Victoria, for example, to access some services. So this is a bigger thing because I guess it's about funding, but, either upskilling people in other states to be able to do some of the more complex clinical work around FGMC. And again, I agree with just general awareness of, including it in university curriculum, etc.
Yep, thank you. Parissa?
Yeah, I think I'm gonna go with the same thing about looking at it from a more international perspective, like what is something we can do. But I'm gonna sneak in a question. Is cost ever a issue for women who have experienced FGMC to access the help and support that they need? Then maybe that is something to address more urgently. Do we ever get cases where woman or a person who has experienced it cannot gets the support or the help that they need? Yeah, what is it like cost-wise for women to get help in Australia?
I think one of the problems with that, if I can just start responding to that, is the level of resourcing across each state and territory is really different in Australia, Parisa. So that would be my initial response to that in terms of how that affects access to services.
So what does it mean? Like not all states have the right services?
Yeah, that's right. Victoria is, I think, as in my understanding, is the most well-resourced in terms of services available for people affected by FGMC. But one of the themes of our consultation late last year was that there's been diminishing resources over the last 10 years, which our team at Multicultural Centre for Women's Health has been observing since we started NETFA 10 years ago. The resources keep diminishing when it comes to supporting people affected by FGMC and raising awareness on FGMC and all of that.
In the states where there are resources, is it easily accessible for people to use those services?
It's variable, I think, and that's what Gianna was talking to as well. Yeah. Any other problems, everyone, that you would like to raise with this group as possible collaborative projects that we can work on together? Nope. Okay, so it sounds like...
I'll just say, yeah, I'm happy to assist with guideline development or anything like that. In my role, that's part of my job for next year anyway. So trying to do a new one for New South Wales. So I think it's a great idea if we can work together and get a nice streamlined one. Yeah. So
wonderful.
Feel free to contact me.
Thank you, Linda. I think, Catherine, did you have your hand up? Catherine, did you have your hand up?
Yes, I do.
Yeah, do you want to go and then Bree?
Totally, yeah, that's all right. I totally agree with what everyone is saying regarding the generalized guidelines and also education, which is an important tool for us to establish what we're trying to achieve, because that needs to be really addressed, because sometimes we can get the guideline, but if the education is not there, people are not going to be aware about it. And also another thing that I would like for us to put into the guideline is the follow-up plans, because especially if let's say for example a woman an FGM patient delivered at Westmead, Sydney, and then 2 days later she's going to Queensland. So what is the follow-up? What needs to be done? And then sometimes they can have hidden motive of, as I said earlier, and a few other speakers has also said it, of planning to take their female child to their country for them to undergo the Cruel Act. So follow-up is very, very important, because if that gets missed, then it's just going to keep repeating itself. So I think if we can add that to the guideline, I think that will really help. And education is a paramount tool for it. Not just in the hospital, as someone has also said, to be part of the curriculum in the universities and also in the community as well.
Yeah.
So if we can share it everywhere, and if there's any clinic that needs to be, shared as well. So yeah.
Thank you. Thanks, Catherine.
No,
Bree,
that's
if
all
it's
right.
okay, I did see your hand up, but do you mind putting it in the chat, or you could email me as well if there's anything else you'd like to raise. Everyone, I will wrap us up for today. I really want to say a big, big thank you once again to all the presenters. So just a big round of applause to all the presenters. And I wanted to just share what's what's next for NETFA, because actually some of the things that some of the ideas we've been sharing, we will already be working on next year. So we are currently finalizing those resources co-created with the women in the NETFA Leadership Program. And our plan into next year is to support these women in their visions for change using these resources. So that's where all of you definitely will have a role to play to support these women in educating their communities, in educating the healthcare professionals in their states and territories. So we will absolutely love to keep working with you on that. I hope it's also okay to say, Monica and Angela, that you are one of the university partners that we're working with as well in developing an education module using some of the podcasts by two leaders who are based in South Australia. So we are working really actively to integrate FGMC education in university settings as well. So I'm gonna go away and think about all of these problems and challenges that all of you have identified, but I feel like there's a really strong agreement that a national guideline of some kind in terms of the management of FGMC for maternity services is a real priority. So please expect that I will reach out to all of you again to draw on your expertise in 2023 and beyond. For now, thank you so much for taking 2 hours of your day to meet our colleagues from around Australia, to build stronger relationships together. And I really, really look forward to working with all of you next year. So thank you. Have a good rest of the year, everyone. Oh, hang on. Can we, with your consent, can we take one group photo together? Yeah? Okay, great. All right, and let's just do a freestyle pose, whatever you feel like, to capture your mood right now. All right, 3, 2, 1. And another one, just to be silly. 3, 2, 1. Thank you. Thanks. Oh, nice one, Catherine.
And I hope you're going to share with us as well.
Oh, is that okay with everyone? Can I share the screenshot?
Yes, please.
Wonderful. It's been an honor learning from all of you today. And thank you so much for your questions, your comments, and your passion in this space. Thank you.
Thank
See you next time.
Thank you, Rani.
Thanks, everyone.
Bye.
Bye.
Oh, Fidelity, nice to see you.